So excited for this, guys. Stick around. We have an incredible guest with us today, Dr. Matthew Calkins. Dr. Calkins is board certified in family medicine and graduated summa cum laude from the University of Florida College of Medicine with his mission to motivate and empower patients to take control of their own health through the power of the low-carb diet. He also plays a pivotal role as a chair of the Resources Committee for the Society of Metabolic Health Practitioners, or SMHC, where he curates invaluable resources on nutrition and metabolic health. I'm honored and excited. Dr. Matt Calkins, welcome to the Ketones and Coffee podcast, man.
Thanks for having me. Glad to be here.
Yeah, we talked about this before we went live. I recently had your wife on the show, Dr. Laura Buchanan. I told her when she came on, at such a young age, you guys are already at the forefront of change, already changing a lot of people's lives. I mean, how many doctors can you actually say that they have helped a patient reverse chronic illness, right? Like insulin resistance, right? It doesn't happen with traditional healthcare systems. That's why I'm so happy to have you on to share your journey today. A young medical doctor trying to change the healthcare landscape is a tough task to ask, right? But I bet it's a fulfilling one, and it may not have started this way for you, but you certainly didn't brush it off, right? And you continue to go on the search to find the truth, right? So I want to start us with, can you share with us how this transition happened, what sparked your interest, and what led down this path of exploring the connection between lifestyle and health?
Yeah, of course. And Laura is certainly my greater half. So I hope I can live up to her podcast with this one. And I think really my story starts in undergrad. I was a physics major also at University of Florida. So I went there for undergrad in med school, and I was pretty dead set on going to get my PhD in physics. And I just remember one day in my senior year of undergrad, I was in the lab and I was like, I like the intellectual aspect of what I'm doing, but I really want to have more. I just want to talk to people more. Like I want to have more of that interaction with people. And I shadowed a medical doctor, and I was like, this is pretty much it. It combines what I like about physics, the intellectual aspect, but also helping people, talking to people. So knew nothing about metabolic health at that point. I've had been resistance training since about 7th grade. That was about the only thing, but I never really paid attention to carbohydrates, fats, or protein in my diet. Went to medical school, got into Florida, met Laura right before medical school started, and neither of us were on really the metabolic pathway yet. Studied hard for the first 3 years, and I think somewhere in the 3rd year, we both found podcasts, and essentially the first one we found is Low Carb MD. And so that's run by Tro Kalayjian and Brian Lenskis. And we started listening to these awesome stories of patients that were able to improve their health, get off of medications, which in med school, I've heard of. The first class we took really in med school, that first couple of months, was actually just an overview of diabetes. And the reason I think they did that is when you try to study type 2 diabetes, you have to learn about the endocrine system. You have to learn about basically every organ system, because every organ system is affected by diabetes. So it's a very whole body view. And not once during those 3 to 6 months where we were learning about all the different pathways and how diabetes affects the body, were we ever told that it could be put into remission, or you could improve it with really long-term lifestyle alone. So before even listening to those podcasts, I was pretty dead set on going into emergency medicine, because that's the first physician I shadowed way back when in undergrad. And so I ended up matching into emergency medicine. And I realized pretty quickly in the residency that it wasn't for me. So how it works in the US is you have undergrad. So you typically get a 4-year degree. And then I would say 95% of people they'll go into medical school, which is 4 years. And then you match into a residency, and residencies can be as short as 3 years. Family medicine, some emergency medicine programs are 3 years. Internal medicine is 3 years. Some can be as long as, I believe, like 8 years for neurosurgery and stuff like that. And then after that, you're truly a full-fledged attending where you're out practicing on your own. So I matched into emergency medicine, decided it wasn't for me for a couple of reasons, which we can talk about. And then I was seeing Laura even month 1 of residency, which we call intern year. You're basically just getting your feet underneath you that first year, learning how to like navigate the healthcare system, put your orders into like the EMR, and she's actually helping people. I think she had some with A1C improve from like 10% down to 7% of lifestyle alone, which is unheard of from medical school. And I was like, I want to do that. So made the difficult, but I think ultimately not a day goes by where I know I didn't make the right decision, which from emergency medicine to family medicine, and finished residency in June of 2023. So still this year as of for a few more days. And now I have a job as essentially I'm doing urgent care. Plus I have a pilot metabolic health clinic. So what ended up happening, I signed a contract with urgent care, but it's for it's a physician owned clinic system. And it's very nice. There's like 20 clinics in the Western North Carolina area. And I was really passionate about metabolic health. They already knew this. At this point, I was already on the chair of the resource committee for the SNHP. And the person who hired me said, hey, our CEOs, which are physicians, and they still see patients. The entire thing is run by physicians. They're like, you should go give a talk on what metabolic health is and how you can implement it. So I went down to Charlotte where we're headquartered, and I gave like a 30-minute metabolic health pitch deck. And it was to the five physician CEOs. And unbeknownst to me, one of them had already lost about 150 pounds on South Beach, which is a form of ketogenic diet, and he kept it off. And so they already knew exactly what I was saying, and they were already on board before I even brought it up, which was it was awesome, essentially, because they already knew the power of lifestyle changes, and they're on board with trying to rein in this kind of sick care system we have where people tend to just progressively decline if you treat them with the standard of care, which is medications, and it becomes more expensive for both the patient and overall the healthcare system at large. And the only way to really right the ship is to try to improve things from the underlying foundation, like try to get at the root cause of these problems and fix the problems, which is truly due to lifestyle, the diet, the sleep, the exercise, and the stress mitigation.
I love that story with you and Laura and how you got into metabolic health through just your own experience. And same with Laura, and what are the odds of like you two have interest in metabolic health, meeting each other in school, right? That is something, right? When I had Laura on the show, we talked about the pushback she faced during med school, right? And I actually want to ask you the same thing. I ask her, because outside of the low carb community of doctors, I know the pushback is intense. Asking for additional testings are almost impossible, and ego runs deep with the doctors practicing the traditional healthcare system. We can talk about that later. I have a story about that. But what is that like for you, practicing this way? I know you did tell a story about when you got after med school, you're already practicing at a clinic. But was there any pushback that you faced within school or after school?
Good question. For medical school, you basically keep your head down during your clinical years, and we did bring it up a lot. Laura brought it up, I think, more than I did. For residency, different story. And it's a great question because I think it highlights the very important role that you're doing with the podcast and that others are doing to basically spread the word. Because otherwise, if Low Carb MD podcast didn't exist in I think we started listening to it either 2017 or 2018, like pretty early on as a pretty new podcast, we would never have really even gone down this path because it's just not taught. Laura basically paved the way for me. So she was a year ahead of me because I switched from emergency medicine to family medicine, but we both went to the same family medicine program. So by the time I came through, I could basically order my fasting insulins and I could basically tell my attendings when I precept with them, like you'll see a patient and if you have to go discuss the case with the attending before you can basically let the patient leave the clinic. And Laura had fought the good fight to get fasting insulins on patients. And the one pushback you would get from these labs is, well, how does it change management? Which is probably one of my least favorite phrases in medicine, because the number one thing we have, the number one most You can look at it in terms of time or expense or anything that we have for our patients is our time as physicians. Like we have generally 15 minutes, maybe if you're lucky, 30 minutes. And anything that allows me to show, I basically, every time a patient comes to me, I pull up all their labs on the computer and I go line by line to say, look, the triglycerides are this and your HDL is this. And this means that you have insulin resistance. Anything that can help me motivate the patient or further risk stratify them into maybe a higher risk. Like if they're fasting insulin steadily, which I've seen before, that's a pretty high risk patient. And it's going to be harder for them to sustain their lifestyle changes. So they may need to follow up in 2 weeks rather than 4 weeks. That's literally how it changes my management. I think physicians have this tendency to discount their time and overemphasize medications because you don't start a medication based on a fasting insulin level. But it does change your management based on how you interact with that patient. So Laura was able to do that before me. So I was able to order the fasting insulins like with no problem from the attendings. She also fought the good fight to not automatically put somebody with an A1C of 10 to 11% on insulin, the patient that she had improved from the double digit A1C to lower to like 7 or 6.5. Guidelines would say that you should start insulin on that, but they improved it through lifestyle and you just cut out the carbohydrates and then the A1C just came down. And I could basically do that as soon as I got into residency, family medicine residency, because Laura had already done that. So paving what you're doing and what Laura did and what everybody does as they kind of blaze these trails is the trail is then paved and it's easier for the next person to walk on.
Yeah, no, exactly what you said. And, your patients are so lucky to come across Laura and yourself and others who, other doctors who practice a low carb lifestyle intervention, a way of treating conditions, because otherwise, if someone come across low carb and their doctor is dismissive about lifestyle changes, what are the chances of them firing their doctor, right? Chances are they'll believe their doctor. And obviously, from my own experience, our doctor would say, I wouldn't recommend it. Something that hasn't been done, right? Along those lines, right? But your patients, Laura's patients, I am so happy for them because my family, my dad, type 2 diabetic, my mom, pre-diabetic, and their doctor is dismissive about lifestyle changes, and particularly low carb and ketogenic diet. So, as much as I would want them to fire their doctor, never gonna happen, right? Because they've been with them for so long. That's why I love having you here, because I want to ask you questions about how a patient and a doctor can really collaborate in changing their lifestyle and changing this healthcare system together. So I want to ask, what's the biggest challenge do you think in getting more widespread acceptance in the mainstream healthcare for low carb and keto, do you think?
It's also a great question and the answer is pretty complex, and I'll probably ramble here a bit, but I think we could start all the way like on the foundation, I think, of why we are in the current predicament we're in. Because if you look at the data and you look at the guidelines and you look at the major organizations, there's actually support for low carb. We'll just talk about type 2 diabetes because that has the best evidence behind it. But there's even recommendations for treating things like obesity, weight concerns with low carb. So both the American Diabetes Association and the American Heart Association as well, the AHA, both say that reducing carbohydrates in type 2 diabetes has the best evidence for improving basically glucose, glycemia, your A1C. So from that alone, if somebody does have type 2 diabetes and a physician says they can't recommend it, they're not practicing true guideline type medicine. It is 100% reasonable if a patient wants to do a low carb diet and they have type 2 diabetes to recommend a low carb diet. The Obesity Medicine Association as well also basically has endorsed low carb diets in addition to the other types of dietary patterns. Like it's on the same level as low fat diets, low calorie diets, low carb diets. There's basically 5 to 7 different diets that the Obesity Medicine Association discusses in their conferences and basically has endorsements for, in addition to their medications and their waist surgeries that they have. So it's kind of written in there. And I just don't think physicians are still stuck in the mindset of like the 90s where it's the Atkins diet and it's going to kill you, which is not what the data shows either. So the going all the way back to, I think, just medical education decades ago, we have this patient physician model called paternalistic medicine. And this was all the rage in the 60s, 70s, 80s, 90s, like maybe even through the 2000s, where, for instance, if let's say you get cancer and you go to your doctor and the doctor says, you have this cancer, you are going to do this chemotherapy, regardless of how long you're going to live, what your quality of life is going to be, what your personal values are. And really it's the paternalistic, the physician is the father figure and you're going to do exactly what they say. We have since moved to what we call the shared patient physician decision model, which is where you take into account the patient's values, you take into account patient preferences, and the job of the clinician at that point, whether it's a physician, NP or PA, just whoever you're seeing for your healthcare, is really to let you basically discuss the data with you, kind of let you know the options that are out there and what options are more reasonable than others. And honestly, the number one term I use in my visits with patients is reasonable. Like, it is reasonable to do this and it is reasonable to do this. And sometimes I do say, they ask me for my opinion and I would say, based on my personal beliefs, I would probably do this based on what I know, but other people are different. So when you frame it like this, combined with the excellent data we have from things like Virta Health, the Virta Health study, 2-year data, which shows that literally all metabolic markers, except for one, which is LDL cholesterol, improve for if you treat type 2 diabetes with a low carb ketogenic diet. And even then, even though the LDL goes up by about 10 points, the ApoB, which is a better marker of basically the LDL cholesterol, the lipoprotein particles, doesn't change for these patients. So even that's with that data, plus if a patient chooses to want to go on this diet, it's completely reasonable. And I just think that these physicians are stuck in both the old style of thinking with paternalistic medicine, and they're stuck in the old style of data with thinking that the Atkins diet is going to kill you, which was never true anyways. And they're just not up to date with the most recent guidelines from the ADA, the AHA, and the OMA saying that low carb is a viable option.
I also think that the way you present it to your patient, right? You know how Laura has this skill and you have it too, and how she presented it to, she talked about it and she told the story and how she presented it to the patient. And I find it so that the patient have all the information in front of him, right? And she explained it in a way that they understood, especially with CGM monitors, and just make sure that you don't go up a certain marker. And by presenting it that way, and by presenting it in a way that the patient understands or your organization understands, you find that they're more reasonable, right? They can be reasoned with. And so I think there's the power in presentation too, as well. And how you articulated your ideas is as important as the information itself. So I believe you guys have that skill on persuasion, right? That may be one of the key points on why you and Laura is very much successful in promoting low carb diets, right? And I believe that's the case. I want to ask you, do your patients find you specifically from low carb community, or do you also get sort of walk-in patients too?
Almost all of my metabolic health patients currently, because it's a pilot clinic, are from internal referrals from our clinic system. So we had our first kid that was born a day before I finished residency. And then I took 3 months off. So I started my true attending job October 1st. And then, so I've only been working at this point for about 3 to 4 months. And I have probably 30 patients so far in my metabolic health pilot clinic. I'm hoping to get probably about a census of 100 to 200. And then if I have 50 follow-ups or so, I can finally bring data to the CEOs and say, look, here's what I'm doing. And I've already had a couple of patients follow up and they're doing fantastic. Ideally, longer term, we would open up a standalone, comprehensive cardiometabolic health clinic where we would have basically, there would be me doing keto. There's somebody else in our clinic system that does veganism. If somebody wants to try to improve their health with that or be a vegan, vegetarianism, honestly, I'm a very pragmatic person. And at the end of the day, I want to put hospitals out of business. And I'm good at low carb ketogenic diets. And I do believe that there are unique benefits to low carb ketogenic diets that other dietary patterns don't have. But if somebody were to fail a ketogenic diet, and let's say they were to succeed on another diet, and if they were to put their diabetes into remission that way, I would just like high five them and shake their hand and hug them and like congratulate them, because at the end of the day, I want the last 24-hour shift I did in the hospital during residency. So every other Monday on our inpatient service, you have to basically almost stay awake for a full 24 hours. You may get like 15 minutes of sleep overnight, but you have to, you're basically admitting patients. You're putting out like any fires that happen to pop up if somebody gets sicker on your service. And at 2 a.m., I was paged about somebody who had a pretty bad foot infection. It's called necrotizing fasciitis. And it's basically the worst kind of skin infection you can get. And it has to go immediately back to the operating room. And it was on their foot, and it was from a diabetic ulcer, right? So a longstanding complication of diabetes is people lose sensation in their feet. They also get poor wound healing. There was another patient that had diabetes that, to just give you an idea of how bad it can get, one day they were noticing blood on their carpet when they were walking barefoot in their home. And they realized that their foot was bleeding, and they had a nail. They were a construction worker. They had a nail in their boot for 2 weeks.
No.
And that was a different person, but basically they had to also go back to the operating room. So this current patient I had a really bad infection, went back to the podiatry OR at 2 a.m. and they were the sweetest couple, like 60 years old, 65 years old. And at that point, I felt like it was my mission to put podiatry ORs out of business at 2 a.m. I don't want a single podiatry OR in this country to be operating overnight. I want no more diabetic amputations overnight. I want no more diabetic amputations at all. Yeah. I want no more diabetic ulcers. So whatever a patient can do to do that, I'm on board with. And whether it is, I do believe low carb keto is what I practice. I'm just good at it. And I think there's benefits, but other diets can work as well. So long story short, there's somebody else in the clinic system that does practice like whole food plant-based, which is perfectly fine. And then in this other clinic that we will hopefully create, you would have an associated gym with it, right? Because that's one of the pillars. Yes. You would have exactly exercise. So the 4 pillars, what we talked about earlier, is the diet, the exercise, the sleep, and the stress mitigation. Yep. So hopefully there would be a psychotherapist, there would be personal trainers, physical therapists there, and even maybe a special agreements with like a CT scan, a radiology company where we can do calcium scans to fully evaluate some of these cardiometabolic health and do advanced lipid markers, advanced cardiometabolic markers. That's the decade-long dream of where we want to end up.
That's an ideal way to. That's probably 5 to 10 years, 5 years.
I'm hoping.
Man, that's that whole spiel that you said there. It's so powerful, right? Because I can see your passion for helping your patients, man. I mean, I'm with you. I'm with you on this fight, brother. If I can, however I can help you to push your message, I will. That's why I want you to. These questions that I'm asking you is for our listeners to empower themselves, right? And maybe teach them to stand up to the system, the traditional healthcare system, not all are, we cannot talk about bad doctors. Not all are, right? The ones that I know at least can be very dismissive about lifestyle, but they're all well-meaning, right? So, and also they are sometimes get very egotistical in terms of asking for testings and so forth, right? I had
Right.
an experience where a doctor, my mom, I told her to ask for a CAC scan, right? Um, calcium for a calcium score test, and she started asking for, where did you get the information? She was triggered by the question. But this is why there's a barrier within the system where a patient really has a hard time of, it's either I fire this doctor, they have conflicting information about lifestyle and traditional medicine, and it's just so confusing for a lot of our people here, who has, especially those who are chronically ill, right? And this is, I want to help them uh, navigate traditional healthcare systems. At the end of the day, many patients are concerned about, right, like I said, conflicting information between medical guidelines and their lifestyle change, right? I want to ask you, Matt, how can individuals better understand and discuss this with their maybe healthcare providers, do you think?
Yeah. And to reiterate your point, you're doing a fantastic job with with the podcast alone. Like, if there's anybody listening to this, it doesn't matter if you're a medical student, a resident, personal trainer, somebody like an engineer, or anybody else in any other profession. There's actually been more engineers in this space over the past 5 to 10 years who decided to get interested in health that have probably changed the landscape more than
Mm-hmm.
99% of physicians or PhD
Mm-hmm.
researchers. So whatever you're doing, if you're listening to this and you're just like, well, I'm just X, Y, or Z, don't, that's not, that's not true. We got into this, Laura and I did, through a brand new podcast in 2018, and it kind of snowballs, propagates forward, and the inertia eventually just kind of takes over. In terms of talking with your physician or your clinician, a couple of low hanging fruit would be at the SMHP, so the Society of Metabolic Health Practitioners. We do have some handouts that you can download to take to your physician. Basically, one is an intro to low carb for a clinician that isn't totally aware of what it is. So if you Google that, and then there's the resources tab, and one is for providers and one is for patients. And if you click on for patients, then there's a handout that you can take to your clinician. And it has Virta Health data on it with improvements in A1C for type 2 diabetes. It has Dr. Tro's medical weight loss data he has a pilot program for a self-insured company, factory company, and basically the improvement in weight and A1C for them. And also Dr. David Unwin, who is another low carb practitioner over in the UK, and his data. So we have 3 different kind of clinics that have shown remarkable improvements in lifestyle alone in a nice little table there. And then it has, what is a low carb diet? And then finally it has information on, is a low carb diet going to kill somebody with a heart attack? And then basically the improvements in all of those studies of every cardio metabolic marker basically hopefully should assuage those fears for those clinicians. Otherwise, I think that at the end of the day, it has to come back to just reframing, I think, how this is important to you. And it's hard for me to really, I have seen this so often on like Twitter, social media, where patients say, I saw my doctor today. And actually Laura deals with this a lot too, because she works for Dr. Tro. And so they see a lot of patients who have improved their A1C markedly with low carb, but then they go to another doctor, like a consult, maybe a cardiologist or an endocrinologist, or even their own primary care doctor. And they say, oh, it's great, you've lost 30 pounds and your diabetes is in remission, but low carb or high fat diets are going to kill you, going to cause a heart attack. And that's sad. I don't know. I think the best thing is just grassroots, continue to educate as many people, and it will kind of percolate through the medical community as well. It on average takes about 10 years for the latest data to reach the community, like primary care doctor anyways. So we're well on the way.
Okay.
I do have a lot of hope though, because there's Laura and myself are evidence that the younger generation gets it. All of our co-residents are totally on board with low carb. They may not know how to recommend it, but they know that if a patient is on low carb and they're improving their health, that they wouldn't have to tell them to stop it. Like that they wouldn't disregard the improvements that they've experienced. And there are even a few co-residents that do practice low carb as well. Whereas I would venture to guess 5 to 10 years ago, it was much worse than that.
Yeah. I believe so. I believe we are on our way, and if it takes 10 years, and then it takes 10 years, right? But right now, what you can do right now, you can take control of your own health, right? There are practices that exist today, like Dr. Tro's, like your practice as well, right? That are already helping a lot of people reverse chronic illness today. So you don't have to wait 10 years, right? It will happen, hopefully, right? And there's a lot of people working together, the podcast experts who are in the forefront of changing the landscape of traditional healthcare systems. And hopefully we are on our way, right? I want you to talk about is it DBA that you talk about, or the direct patient care, DPC, sorry.
Oh,
yeah.
DPC.
If you could talk about that a little bit, and what's the difference? Because this is the future, I think, of healthcare, and which is a lot more sustainable, a lot more direct to patient, and patients actually learn a lot when going into programs like this. So if you can elaborate on that program, that DPC method, if you can explain.
Oh, yeah.
Yeah.
Yes, I love DPC practices. I'm not in a DPC practice, and I'll talk about the differences, because I think it's one of the most fascinating areas of medicine that is likely to change the most within the next 5 to 10 years. So DPC is direct primary care, which means that there's no insurance company. So you have we'll just say physician, but it could be any clinician, which is an NP or PA. But you have a physician and they have a practice, and they can have a brick and mortar store. It can just be telehealth. Really, it doesn't have to be in person. And they generally have a patient panel of maybe 600 to 1,000 patients. And those 600 to 1,000 patients pay, I think on average, it's about $50 a month in order to see that physician. And the beauty of that is, in the old model, which we'll talk about in a second, you generally have 3,000 to 5,000 patients. So imagine being one physician. You have your EMR, which is your electronic medical record, and it's like on your computer screen, and everybody has access to you through the in-basket. They can just send you messages. And imagine trying to respond to like sometimes 50 messages a day. It just doesn't, it's a burden placed upon you by the current healthcare system, and more specifically, the administration of the healthcare system. But that's like it's a whole other rant that we could go on. So you have smaller, more, I guess, intimate kind of environment with the direct primary care model. And you generally see about maybe 6 to 8 patients a day, as opposed to 20 to 30 patients a day in the older model. The pay is a little bit better for direct primary care. We'll talk about why that is too, for the physician themselves. But the beauty is there's no insurance company to come between the care from the clinician to the patient. So the visits are generally 30 minutes to an hour long, and you have time to fully discuss, like, should we get this lab? Should we get this test? Because labs don't go through insurance, typically with the clinician's job is to go to LabCorp request and say, hey, how much is it going to cost for a comprehensive blood count? How much is it going to cost for a comprehensive metabolic panel? How much is it going to cost for a fasting insulin? And you do that, and you essentially are able to give your patients a sheet that tells you how much each lab is, which is unheard of in current medicine, because you don't know how much any lab is for any patient in the current medical system through insurance, because it's all different for every single insurance. So patients know exactly how much they're going to pay. They get way more time with their physician, and they have the ability to get same day appointments as well, which is also something incredibly hard to do in the current system. those patients should still have catastrophic insurance. If they were to just travel on the highway, get into a car accident, have to go to a trauma center at the emergency department, then that is something that they should have covered. They should have like maybe a $3,000 deductible or something like that, just in case something catastrophic were to happen. But the whole point of DPC is we're going to decrease your overall healthcare utilization because you're going to be healthier. You're not going to die. You're not going to get diabetes in the first place. Yeah. If you have high blood pressure, we're going to follow up and we're going to get your blood pressure better just by losing weight. The best blood pressure medication we have is weight loss, period. So if you can decrease somebody's medication burden, decrease the side effects, just by not putting them on the medication in the first place, you're going to save money. So then that's direct primary care. Essentially, no insurance to come between clinician and patient, longer visits, you know exactly what you're going to pay. And overall, it's cheaper for the patient, even with the catastrophic insurance, because insurance is so expensive nowadays. So then how does that compare to the old school, like what we do now? So we have each physician has about 2,000 to 3,000 patients, and you generally get 15-minute appointments with the physician. And half of that is really just like a lot of administrative type stuff, if that makes sense.
Yeah.
Basically screening and the physician doing the note and things like that. And then you don't know how much your visit's going to cost because each insurance is different. The copays are different. Your deductible is different. They may or may not cover the lab tests that you want to get, the calcium scan, things like that. And the incentive, I think, for the clinician is the biggest difference between these two. So in the traditional model, if you can't be salaried, but it's a little bit more common nowadays to be paid by what's called RVU, which is revenue value unit. And this was a system created in the 80s and 90s where they tried to normalize the unit of work that, let's say, a primary care doctor does and an orthopedic surgeon, right? So just making it easy, let's say one primary care doctor visit is one RVU, and then they could basically kind of equate that to maybe 100 RVUs for an orthopedic surgery, which takes 5 hours. And it's a very complicated process. And there's a lot of things that could go wrong, but they wanted to basically have one standardized scale to where they could pay all physicians based on this unit. And so the thing that drives up the RVUs for primary care physicians specifically, it could be time. So you can bill by time. So a 40-minute visit is like maybe 3 RVUs, and a 30-minute visit, I think, is like 2 RVUs, and a 15-minute visit is 1 RVU. But the other thing you can do to increase RVUs is manage medication, which essentially means prescribe or change doses. It could mean deprescription as well, but in reality, for 99% of what we do in medicine, it's adding on medication or upping the dose of the medication. And so you end up with a lot of very short patient visits where you manage a medication, and that gets you the most RVUs per unit time in the old model compared to the direct primary care model, where there is no additional cost or there's no additional benefit for the physician at all of putting people on medication. There's actually benefit for keeping their patients healthier without medication to keep them happier and to keep them out of the hospital. And everybody's happy at that point.
Yeah. Both sides are happy, right? It just helps both sides, the medical doctor and the patient. And also gives the doctor has a lot more time to educate their patient on. My biggest thing is to educate the patient on what the diagnosis is, because most of the time, people get diagnosed, but when they go home, they don't know what they have, right? They would search online, but what are the chances that what they find is accurate, right? So with this model, I believe that for a minuscule amount a month, it helps a lot because there's so much that the patient can do, and with empowering them with education and what they have and how they can navigate lifestyle intervention to reverse their symptoms. It just helps everybody.
100%. If a patient leaves my office and if they don't understand
Mhm.
what either new diagnosis that we had that visit, or they don't understand the actual reason why that happened. I explain to every patient why they have high blood pressure. I explain to every patient why they have a weight concern, or even mental health, or even type 2 diabetes. Like these all have underlying, at least some of the underpinnings. And I would venture to guess even more than traditional medicine says at this point, as you're aware, that they have their underpinnings in metabolic health. And the way we're going to improve that, like, because I'm just good at it, they can do any diet they want, but like low carb ketogenic diets for me, I think even for mental health concerns, now that we have Chris Palmer is doing excellent work, Georgia Eid is doing excellent work. In fact, I had one patient follow up. I've had probably 5 patients so far follow up. One patient followed up, lost no weight. 1 month follow up on a ketogenic diet, lost no weight. And I was like, oh my goodness, I'm going to go into the room.
Yeah.
She's going to say she hates it. She's not losing weight. She's going to be mad at me. And I go into the room and I'm like, so how are things going? And she's like, it's going amazing. She's like, I feel great. And she never even brought up the weight. She's like, I feel so much better over the past month than I have in years. And that was a light switch, like a light bulb for me. And I realized that it basically solidified the fact that it's not always about the weight or the A1C. The improvements in mental health can be so profound that the patients don't even care about the weight at that point. Dr. Eric Westman, Laura and I worked with him during residency. He's at Duke Keto Medicine Clinic. And he's a mentor of ours. And he has my most favorite phrase about the ketogenic diet, which is, it's so unbelievable. It's unbelievable. You have to be careful if you're not talking to somebody who's like in the know of a low carb dieting, that you can't really go out and say, hey, I got a patient who lost 20 pounds, and I got another patient whose A1C improved by 3%. And I got another patient whose PHQ-9 or their depression or their anxiety or these other like screening things, they've all improved like within the first month, because it seems crazy, but we just see it every single day in clinic, and you see it all the time on basically testimonials on the internet. It's almost like from the internet's perspective, it's like crowdsourcing data at that point, and it just works.
And I'm still in awe of this. It used to be devastating to be diagnosed with insulin resistant, type 2 diabetes, prediabetes, because it's viewed as chronic, right? And that means that you'll be on medication, on management drugs, right, to manage your blood sugar levels. But gives a lot of people help now, right? That's my thing, is to, all right, give them an option of lifestyle change. And if medication is an option, then give that option, right? But if you have an option to change our lifestyle and reverse type 2 diabetes, for example, then I want that on the table, right? For everybody, right? And that's our only ask, I believe, at the end of the day, right? You can't ask everybody to make a lifestyle change, right? But realistically, if we have both options on the table, then those people who are ready to make that change have an option, right? And that's why I love your practice. That's why I love what you guys are doing. You, Laura, Dr. Cho. I'm really honored to interview you, Laura, and other experts you guys are so young, and you guys have a lot of things you'll see it through to the end. And I believe it's going to change, and it's only a matter of time at this point, because, the evidence is there, right? And you said this is already endorsed, and, it's just taking time to reach other physicians. And if we can keep working, keep improving, and keep the message going, then we'll be there one day, right?
Exactly. Hopefully sooner than later.
Yeah, absolutely. Man, this is so great. If we miss anything, Matt, if you want to say something, this is your chance. But like I said, you guys are already at the forefront of change, and this is such satisfying work for you. And I believe that you and Laura has a great career ahead of you guys.
Yeah. It was great to be here. I think the theme of our discussion is perfect. And I think it's just the number one takeaway I always have for patients, which is you have to be an advocate for yourself.
But
You're absolutely right. There is I think it's physicians, you ask for certain blood tests because you're interested in your own health, or you take initiative and you do the lifestyle changes yourself, and the physician or the clinician comes back and says, no, we're not getting that lab test, or they get defensive, like you said, for egotism reasons or things like that. But at the end of the day, you're in charge of your own health, and it's the model is really a shared patient physician decision making. And if they're not relaying the data you need them to relay to you, there are direct primary care clinics out there. There are clinicians out there that will have those discussions with you, will give you the data, and then you can come to a decision together rather than unilateral agreements.
Where can they go to find that? Any sort of examples or any you can recommend to our listeners today?
I know for full disclosure, Laura, my wife, works with Dr. Tro. I know Dr. Tro is licensed in 50 states, and Laura's licensed in, she's licensed in whatever state you need her to be licensed in. So right now, I think she's licensed in like 35 states, but it could be 50 if they hit the need to be. There are a lot of physicians in the low carb space, and I'm hopeful we do have a repository of some low carb practitioners for the SMHP. So if you go to their website, you can see who's a metabolic health practitioner. And if they're an NP, a PA, or a physician, then they can see patients, and you can try to see if there's one of those in your area. I think one of the things we should do next on the docket for the Society of Metabolic Health Practitioners is have just basically an interactive map of the US where people can say, I am a low carb friendly cardiologist, low carb friendly endocrinologist, low carb friendly primary care physician, OB doctor. And you can go easily search it and just sign up for somebody who will actually have those discussions with you.
Awesome. Well, that's great information. Thank you so much, Dr. Matt Calkins, for sharing your story with us here today. I want our listeners to be able to reach out to you, connect with you online. Where can they find you?
I am mostly on Twitter, and you can just send me a tweet or I guess X now, or send me a direct message. I am Matt Calkins. That's MattCalkins, MD is my Twitter handle.
Awesome, guys. Thank you so much, Dr. Matt, for coming on and sharing your story with us today and insights. I hope you guys have your notes out. I'm going to re-listen to this so that I make sure that I don't miss anything. There's a lot here. There's a lot of information. If you want to follow Matt, it will be linked in the description box below. And you can connect with him and maybe work with him. If you have a chronic illness that you want to reverse, it is the best time because healthcare is about to change, and you can take control of your own health today. So thank you, Matt, for coming on and sharing your story with us today.
Thank you, Lawrence. Thanks for having me. It was great to be here.
All right. Bye-bye. Thank you for joining me for another episode of the Ketones and Coffee podcast with Dr. Matthew Calkins in discussing his experiences and challenges in advocating for a lifestyle-based approach to healthcare and providing insights into direct primary care and its potential for revolutionizing the healthcare system. I have provided the links to Dr. Matt Calkins' work and his socials. Please see the show note captions below. If you are learning from or enjoying the podcast, please subscribe to wherever you listen to your podcast, which is a great zero-cost way to support the podcast. And you can also leave us up to 5-star reviews on both Spotify and Apple. If you have any questions, please reach out to me on Instagram or our new website at ketocoachlawrence.com.